Hi, I'm Dr. Alex Popadich, and I'm a breast surgeon and menopause specialist dedicated to supporting you through the breast cancer journey as well as perimenopause and menopause. Today, I will be talking about medication most breast cancer patients have heard of, and that's tamoxifen. Whether you are newly diagnosed, in treatment, or considering different options, this guide will help you understand why tamoxifen is such an important tool in a breast cancer management. What is tamoxifen and how does it actually work? So tamoxifen is known as selective estrogen receptor modulator. Certain breast cancer cells that are estrogen positive, estrogen may make this cancer grow quicker. So if we have this cell here with my really great scribbles, you can see that these are the estrogen hormone, whether it's the estradiol, estrone, or E3, they go into the cells and then bind to the estrogen receptor. And then they cause transcription of a lot of factors that cause either cells to grow or behave certain way, depending which cell is acting on. So breast tissue, it makes it grow, in the brain makes it work in a different way, and a uterus, it makes the uterine lining grow. So what tamoxifen does, so you have the same cell and there is estrogen around it. So what tamoxifen does is goes into the cell and then binds for the estrogen receptor. So the estrogen cannot bind to this receptor. So tamoxifen binds, but estrogen cannot bind. But what it does is actually quite interesting. And this is why it's called selective estrogen receptor modulator, or SERM. And in New Zealand, we have just tamoxifen. In America, they have another SERM which works slightly differently. But what it does in the breast tissue, it binds from the estrogen receptor, it blocks it, but it doesn't cause the downstream effect. It basically stops estrogen working on the breast tissue. But what it does in the uterus, it binds to the receptor, but it actually works like estrogen. So it makes it, the lining of it, grow. So that could be one of the side effects of the tamoxifen, where the lining of the uterus grows. You can have some vaginal or PV bleeding, or it has slightly increased risk of endometrial cancer. So as said, in the breast tissue, it blocks estrogen from acting in it, and in the uterus, it works like estrogen. So it doesn't actually block the receptor. It causes the same downstream effect. So when do we actually use tamoxifen? So we use it as a part of the treatment to minimize the risk of cancer coming back in early stage breast cancer. We call this adjuvant treatment. So it's often started after the surgery, after radiation, or after chemotherapy, depending which type of treatment you're going to have. If you have a locally advanced or metastatic breast cancer, we can start using it either before the surgery, which is called neoadjuvant, or as a treatment of breast cancer for metastatic disease. If you have a BRCA family history, sometimes we use tamoxifen to minimize the risk of patient developing a breast cancer. So why do we use it? We want to prevent the recurrence of breast cancer. Most of the time we talk about recurrence somewhere else. We don't talk about the recurrence in the breast or armpit lymph nodes, but we talk about recurrence in the brain or in the lungs or in the bones, or dying from breast cancer. So tamoxifen can minimize the risk. And it actually works for up to 20 years after finishing the treatment. We use it mostly for 5 years. In some cases, or some women who have a high risk of breast cancer, we might use it for 10 years. So most commonly it's 5 years, but sometimes we use it for 10 years. It's suitable for all women with estrogen positive breast cancer. So you have to first have estrogen positive breast cancer, and then it doesn't matter whether you're premenopausal or menopausal women. And we also use it in men, People who should not take tamoxifen are those who have a breast cancer that's estrogen negative. So that cancer will not respond to estrogen, so there is no need to use tamoxifen. If you have history of blood clots, if you have certain liver condition, if you're pregnant or planning pregnancy, or there are some medications that can affect tamoxifen or interact with it. Some women don't tolerate tamoxifen, and like any other medication, it can cause side effects. And most commonly, these side effects are menopausal or perimenopausal side effects, like hot flushes, night sweats, vaginal dryness, brain fog. And we can do different things to support you through that, or sometimes we may even have to stop the tamoxifen. There is also a risk of blood clots, and we're talking more about DVT or deep vein thrombosis rather than arterial blood clots. And it does have a slightly increased risk of endometrial cancer, like we talked earlier. What is your benefit from tamoxifen? We know that it will decrease the risk of recurrence, or what we often more talk about, mortality, by 20 to 30%. And this is relative risk. So let's see this in action. This is a breast predictor we use sometimes to predict people's risk of breast cancer or women's risk of breast cancer. We'll use only invasive cancer. Let's say that woman was 65, she was postmenopausal, she was ER positive, HER2 was negative, and Ki-67 was negative. Let's say the cancer was 10 millimeters. Tumor grade was 2. It was detected by screening, and this woman didn't have any lymph nodes. So if we look that with surgery only, her survival is 83%, and it's not out of 100%, but it's out of 87%. Because this woman is 65, over the next 10 years, 13 women will die from other causes like a heart attack, car crashes, strokes, other cancers, and something like that. So her risk of dying from breast cancer is 4%. So if we give her tamoxifen for 5 years, we increase that survival by another 1.3%. So if we go 1.3 from 4, it's approximately 33%. So this 1.3% is actually absolute risk of survival. So it's the total benefit to her. Out of 1,000 women that we treat with tamoxifen, 13 will benefit. The other 987 would have taken it for no really good reason. Now, if we change something, and the easiest thing to change is just the size of the cancer. So if this woman had a 35 millimeter cancer, it was grade 2 cancer, like before. Now, her survival after surgery is 77% out of 87%. So her survival has dropped purely related to the size of the cancer, not the grade, not anything else. So now, if we give this woman 5 years of tamoxifen, she gets much bigger total percentage benefit. So 3.6 out of 100 women, or 36 out of 1,000 women, will get a benefit of tamoxifen. So it's still around 35% benefit of tamoxifen, which was the relative risk, but absolute risk to this woman is 3.6%, while if you had a 10 millimeter cancer, exactly the same other factors, your benefit is only 1.5%. And this is the difference between the relative risk and the absolute risk. But remember that your treatment plan is unique to you. And talk to your medical team who is involved about risks and benefits of taking these medications. And then you, together with your medical team, decide what treatment options are available to you and are good to you. If you have concerns about tamoxifen or you want to know more about tamoxifen, please talk to your medical team. And that includes breast surgeon, medical oncologist, radiation oncologist, whoever is part of your team, because we are all here to help you every step of the way. Thank you very much for watching this video. If you'd like me to talk about anything else, please put the comments below, and then I can let you know more about different breast cancer treatments or menopause or postmenopause treatments. Bye for now.